Good evening, everyone. Welcome to tonight's webinar. My name is Shelley Vincent. I'm the Marketing and Communications Manager at General Practice Supervisors Australia, and I'd like to welcome everyone to tonight's webinar presented by Dr. Genevieve Yates, supporting GP registrars to manage patient boundaries. Sorry, we're a couple of minutes late starting. We had a few little technical difficulties, but thank you very much to Luke, who's been able to help us out tonight. So we've got participants on the webinar tonight from all around Australia. Actually, it's interesting, quite a few participants haven't attended the GPSA webinar tonight. So I'll run through a few quick housekeeping notes in a moment. Usually on our webinars, though, you're able to see both the presenter, Genevieve, and myself. But due to some bandwidth issues, and just to make sure that you can hear us all very clearly, we'll be speaking over our phones this evening. So you'll just have the slides coming through, and you'll also have the chat box as well there on the left-hand side. I'd like to start tonight by acknowledging the traditional owners of the land in which this meeting is taking place and pay respects to their elders, past and present, and their families. So during tonight's webinar, everybody's microphone will be muted, so we won't have any background noise, but you can still ask questions throughout the session, and you do this through the chat box, which is down on the bottom left. I can see everybody down there has already started sending through a few chats, and good evenings to everybody. We're also recording the webinar. For those that are unable to participate tonight, they can view it later on the GPSA YouTube channel, and that'll be up and running in about 2 weeks' time. So just another quick point for some of our new participants. But I find that if I have all the other website tabs closed during the webinar, the sound and the picture flow a lot better for me. So if you do find you've got a delay on your screen or if it freezes, just be patient because that will often settle down. So thanks again, everyone, for joining us tonight. And I'll now hand over to Genevieve Yates, who I'm sure many of you know already, to introduce herself and to present tonight's webinar. So welcome, everybody, and welcome, Genevieve.
Thank you, Shelley, and thank you, everyone, for coming along to this webinar on this cold Wednesday night. My name is Genevieve Yates, as was mentioned. I'm a GP and medical educator. I've been involved in medical education 2005 now, originally as a medical educator and supervisor in Queensland, and for the last 7 years or so I've been living in northern New South Wales. So currently I am not a GP supervisor with my clinical practice, but I am involved still very much in education and assessment. So I'm the RAC GP Centre for Queensland, as well as working, doing some contract work for various RTOs, working for MDA National in medico-legal education role, for Black Dog Institute doing mental health training, and also working on other odds and sods like doing performance assessments for APRA. So all in all, this particular topic about patient boundaries is very near and dear to my heart, not only because it's highly involved with my current roles with things like APRA and MDA National, but also because I myself was a registrar and a supervisor who had to come to terms with some boundary issues, and so I sort of learnt the hard way as a GPT-1 registrar actually about some of the challenges involved with boundaries, and I think that it is part of our role as supervisors and educators to be able to support our registrars in this quite tricky area. So tonight we're going to be talking about through a particular case. The general outline of the session, we're going to start today with looking at how to teach registrars to identify some unreasonable patients' behaviours and requests, and then basically how to support them through that. The last part of the session, we're going to be talking about the challenges of dual relationships and how we can support, again, registrars, and particularly through looking at practice policies and strategies to help manage and support this for our registrars. So let's start with a case. I'd like to introduce you to Platypus Creek Medical Centre. I should actually add, before I go any further, this is going to be an interactive session, and we're going to have the opportunity for you to voice your opinions, first of all through the chat box in the form of questions and comments, Also, we're going to have some poll questions as we go, so we really would like to hear your views and your thoughts on the poll questions. There's no right and wrong, it's really just looking for your opinions. And then about halfway through, we're going to stop for an opportunity to answer questions and to discuss any of the issues that have been brought up in the chat box. So your question may not be addressed immediately, but just to be rest assured, we'll have the opportunity to do that at the middle of the webinar and also at the end. Okay, so back to Platypus Creek Medical Centre. So this is a theoretical medical centre with a population about 2,170 kilometres from major centre. So you can see at the moment, pretty typical, fairly small regional rural town. It's quite a busy practice. There's visiting medical officer work, lots of procedure stuff, lots of variety, a long-standing teaching practice. The supervisor, Dennis, is also the practice owner. His wife is the practice manager. They've been living and working in the town for about 32 years. And they're very involved in the community through sport and kids and volunteer top committees. They treat the practice staff like family and as they do many of the patients. And quite often the staff do socialise and do hobbies and things together. So the characters in our story are Dennis, I've mentioned, with Penny, his GPT-1 registrar, and Janet, the practice nurse. So Penny is 28-year-old single female. She's really keen on doing rural or semi-rural practice. She comes to the area without any particular ties. Her family all reside overseas, but she's really thinking, yeah, this is the kind of area I could see myself settling down. She's a good girl who likes following the rules. Personality-wise, she's quite timid. She doesn't feel comfortable questioning authority figures, and as say a people pleaser, which is quite easily intimidated. Dennis is actually, although he's been in the area a very long time, he's really getting quite tired of the life and the workload, and his underlying agenda is he'd really like to sell up, move to the city and semi-retire. Both of his sons are now in a university in Brisbane, and he's thinking that it's time for him to move to a different phase of his life. He really loves teaching registrars, but really would love one to stay long term, ideally to buy the practice. And he's actually hoping to convince Penny to do this, but none of his previous registrars had been interested in staying. Janet's a 39-year-old registered nurse. She was born and bred in the region. Her husband owns a local hardware store. She's got two young adult children and has been at the practice for 10 years, working between 3 and 4 days a week over that period. So there are our categories. Our characters. So moving into the term, so a month into Penny's GPT-1 term, she's really quite enjoying herself. She's getting very good clinical teaching, but she's struggling a bit, and some of the things she's struggling about are patients that are asking for blood tests being recommended by their naturopath. There's quite a large alternative type community nearby, and she's kind of struggling with that aspect of medicine. She's finding living and working in a small town quite challenging, and not quite sure how to cope with people who approach her outside the practice and asking for medical advice. She sees her supervisor and the other doctor in the practice being quite comfortable with this, but she feels very uncomfortable with this, but not sure how to address this. And she's got a few that have sort of tried to befriend her on Facebook, and again, she's not sure how to cope with that. So we're now going to go to a poll question. So Shirley, if I can get you to launch the poll. So the poll is asking, how often do you provide specific teaching or advice on patient boundary issues with new registrars? The kind of issues that we've discussed there now with Penny, such as social media, talking to patients outside consultation rooms, and dealing with inappropriate requests. So just going to give people just another 10 or 15 seconds to answer this poll, and then we're going to share the answers. Okay, so I'm now going to share the answers with everyone, and hopefully people are able to see that. For those of you that are listening to the recording, I'm just going to go through the answers because you won't be able to see the actual poll results. So 13% of people said that they proactively discuss these issues with all registrars. Another 13% said they proactively do it with some registrars. 30% said they opportunistically do it fairly often. 34% said they opportunistically do it sometimes. And then another 10% or so said only if directly questioned. So quite a spread there, with the majority saying it's really done as an opportunistic thing rather than as a proactive routine area. So moving straight on to the second poll question now, we can launch that. Please, Shelley. So the second question being, how important do you think it is for GP supervisors to routinely provide registrars with specific teaching or advice on patient boundary issues? So just give you another 10 or 15 seconds. You may have slightly skewed results considering that you have all logged on for this webinar, so you must think it's at least somewhat important. Okay, so looking at those results, so the answers 73% feel it's very important, 24% say somewhat important, and one lone but very important person has just said only if problems or concerns arise, and no one ticks the box saying that it's not really part of your role. So based on those results, it seems the majority certainly think this is a very important area and part of the role of being a GP supervisor. As we go to the next few slides, I'm just going to encourage you to start writing some comments in the chat box that we can address in probably about 10 minutes or so. And I'd just like you to be able to share with the group ways that you feel are effective in teaching boundary issues and professionalism to the learners in our practice. Any tips about how you actually do that, and particularly around things like teaching or monitoring ethical billing in your practice. And also, if you feel comfortable, to share some examples of some common problems or concerns and sort of misunderstandings. And this would be helpful, particularly those that are experienced GP supervisors, to sort of give a bit of an idea about potential problems that some of the newer supervisors may come up with as they get more experience with being a supervisor. So this is a great opportunity to share and use the wisdom in the group. And we'll come back and address some of that in a few minutes, but encourage you to share amongst yourselves. Okay. So going back to the principles behind the professional boundaries and patient boundaries. So as doctors, we are expected to adhere to a very high standard. We are expected, given our position, to be above reproach when it comes to some of the professional and ethical boundaries. And the Code of Good Medical Practice by AHPRA outline these quite clearly. As supervisors, we have an added level of responsibility, not just about to hold these ourselves, but to be able to teach these standards and boundaries to the learners in our practice. Preferably we do this not by the anti-models. This was actually described to me by a wonderful supervisor from Tennessee who was discussing different models of supervision at one of our supervisor workshops, and came up with the anti-model of supervision, as in, this is how not to do it and don't copy me. So preferably we won't do that, particularly not in the professional standards and ethics. So if we start looking at things like ethical framework, I think that a lot of registrars struggle a lot with the coulds and the shoulds. There are those areas, and this is one of those Venn diagrams I think is quite helpful when trying to discuss with registrars about making decisions around billing, prescribing and test ordering. The concept being there are many, many things that we can do as far as practicing doctors go. And there are a number of things that we should do, and hopefully the coulds and the shoulds overlap in most cases. But the idea is trying to work out and help provide a framework for registrars to try and unpack where the shoulds don't overlap with the coulds and vice versa. So to help with that, I think that it's good to have kind of some frameworks to make those scaffolding decisions. So an example for that would be talking about prescribing. So this is a little template that I tend to use with registrars when they're trying to help them decide whether or not they should prescribe a particular medication. The first question I get them to ask themselves is, do I know enough about this drug? Do I know about the benefits, adverse effects to confidently prescribe it? If I don't, look it up. Or to ask for advice. If they're still not comfortable, then it's best not to prescribe it. The second question I get them to ask themselves is this drug TGA indicated for this condition? I find that registrars, and I'm sure you find the same, get very confused between PBS indicated and TGA indicated. And I think it's very much worthwhile explaining this explicitly to registrars when they first start in your practice, particularly GPT-1 registrars, and it's quite surprising how many go ahead, and be in their second or third term and still not really understand this concept. So they ask themselves that. Now, if the answer is no, the question then be, is it commonly used by my peers for this condition? If the answer is no, don't prescribe it. If the answer is yes, consider prescribing it only if very knowledgeable and confident and with informed consent from patients. So just explaining that off-label use needs written consent, or at least verbal consent, and that's documented in the patient record. So an example will be using metformin for PCOS. The third question I get them to ask is this the right medication not only for the condition but for this particular patient? So taking into consideration all of the comorbidities, social aspects, other medications, etc. If not, don't prescribe. The next question, am I allowed to prescribe this medication under these patient circumstances under state and federal legislation? So this particularly is around drugs of addiction and also some of the other Schedule 100 drugs. The next question is about informed consent, and has the patient sufficiently been informed of potential benefits, risks and alternative treatments, and talking about the importance of discussing not only common side effects but serious but rare ones. And then the final question is this on the PBS. So this is an area that registrars do get particularly confused about, and explaining that private scripts are not only a good idea in many cases, for non-concession card holders, for many medications they can actually even be cheaper. So not to be pressured to or think that if it's not on the PBS they can't prescribe it. So just being explicit with them and explaining how to do that. And things like showing them how to, for example, look up Chemist Warehouse prices to give the patients a bit of an idea about the kind of cost that a private script will give them, etc., etc. That's just sort of one example of one of the techniques I use when I'm trying to help patients, help registrars get that sort of scaffolding around ethical prescribing. You can do similar things with things like billing. I think the main thing with the billing is the technique I tend to say is, look, if you are prescribing, again, reminding them with any kind of item they prescribe under the NBS is their responsibility. So it doesn't matter what the practice nurse or practice manager or receptionist does or what you say. Ultimately, the billings are their responsibility. And if they put an item number in for billing, they need to know what the NBS descriptors are. So I encourage registrars, for the first time they bill any item number, they actually go up and look at the full NBS descriptor of that item number, including the explanatory notes. And they don't have to do that every time they have that number, but just to make sure, I think it's a good principle that they've read it at least once and they know what they are billing, rather than just looking at the cheat sheets where they may just have a 1 or 2 line descriptor. So I think, again, it's a good idea they have a really good idea of what the NBS requires for any particular item number. Okay, so the other idea is, as far as other things people struggle with, can be things like drug-seeking patients. So I have, again, I'm sure we all have strategies for helping registrars manage patients with inappropriate requests, including drug-seeking patients. It'd be really interesting to hear in the chat box any particular techniques that you use to help registrars manage this very difficult area. I'll just go through a couple of things that I use to help registrars with this area. The first thing is looking at the broken record technique. So broken record technique, for those of you who are unfamiliar with the terminology, but you're probably very familiar with the actual action, is saying the same thing over and over again. So if someone comes in and requests, for example, pethidine for a headache, the broken record technique will be something like, at our practice we don't prescribe pethidine for headaches. And then when they say something else, I'm allergic to this and I can't this, just repeating the same thing. At this practice, we don't prescribe pethidine for headaches. In the calm, rational voice, but saying the same sentence over and over and over again, not engaging in some of the debate and some of the some heightened emotional discussions and topics that will be brought up by patients in that scenario. So the next thing is practice protocols. And this is where you guys come in. I think we really do need to help and support our registrars by having really clear practice protocols that either are related to the whole practice, but at the very minimum related to the registrars in our practice. So if there is, for example, a rule that registrars do not prescribe S8 medications on a first visit, or if they don't prescribe S8 medications which have not been started by another doctor at the practice, or whatever rules you want to have, if that's just made very, very clear, it gives the registrar something to really hang their hat on. I mean, it's wonderful if the policies do apply to the whole practice. It makes it much easier. But once again, if that's not going to work for your practice, at least having some really firm guidelines and policies that can help protect your registrars. I think also discussing and giving the ammunition about the legal responsibilities of prescribing S8s to patients, particularly to those that are known to be drug dependent. Now that will, of course, that depends on state-based legislation, and those registrars are often not aware of the legislation around these prescribing, and particularly if they've recently moved interstate or into hospital terms in other states. So that's a good idea that's gone through fairly early in their term. So I'm sure we've all had the experience of registrars being preferentially targeted by drug-seeking patients, trying to try out the new doctor, the new young doctor at the practice. So this particular topic and the how to manage these things, I think, needs to be brought up in the very first week of the time in your practice, to give them the tools and arm them with that support first up. And as we all know, if they end up prescribing to 1 or 2 patients in that first week, then it's very, very difficult for them to stem the flow of every man, woman and dog coming in and asking for a similar prescription. I think it's also important to reassure them that and to empower them by saying that the safety does come first, and if they do feel their safety is being threatened, you know, for goodness sake, just describe something and get the patient out of the room, explaining that they can then, you know, call the police, and also having things like duress alarms and describing the kind of safety procedures that are in your practice. So that's just, I'm sure we all have things, and hopefully they will be discussed. I can see there's some wonderful tips being shared in the chat box there. It always helps to hear what has been working for others, and I always get lots of fantastic tips from this kind of session and hearing some of the experience in the virtual room in this case. So they're not just drug-seeking patients that cause a lot of angst with registrars and with us, but also a whole other range of potentially inappropriate requests. So the GANFYD, for those that, for FYI, it stands for Get a Note from Your Doctor. You know, the kind of doctor where they say, you know, please can you certify that Mrs. Jones is going to be fit for her gym membership, etc. So those kind of requests, some of which may be appropriate, some of which might be inappropriate. Insurance paperwork, dental paperwork, etc. Well, of course, much of this is very legitimate, and that there are, as we know, a sprinkling of inappropriate requests. And increasingly, we're seeing this when it comes to things like investigations which don't have a clinical basis and non-clinically warranted EPC items. So I'll go back to the same list as I did for the drug-seeking patients. The same thing about broken records, and going through things like what are the rules when it comes to backdating certificates. With work cover, what are your responsibilities when it comes to how much you have to make a determination on whether or not it is going to be covered under work cover. All those things registrars struggle with so much more than a lot of the clinical medicine. So it's good to not only proactively talk about these issues at the beginning of the registrar's term, but recognise, to encourage them that when they do have their first work cover case or their first disability support pension application, etc., raising it, saying, look, this can be really tricky, please let me know, and we can talk about the particular case when it arises. Okay, so we're going to take a little bit of a break now and have a bit of a chat box check-in. So, Shelley, just going to share about if there are any questions that have come up or any comments or ideas that you'd like to mention for the benefit of those that are listening to the recording, and also to share with the group.
Yeah, fantastic, Genevieve. Linda actually had a question just a couple of slides ago. What about the NDIS paperwork? So what's your comment about that?
So exactly the same. So the NDIS paperwork, I think all of us, it's obviously very new, and we're still trying to work out where it all fits in. So I think if there's any kind of paperwork in which there is the potential for inappropriate requests, or at least doctors not knowing what their responsibilities are. If we are struggling with it, we know that registrars are going to be struggling with it several times over. I think another sort of principle behind this is often for these kind of forms, whether they be driver's license medicals or support, central link certificates, etc. Quite often patients will come in and see the registrar because they maybe cannot get in to see their regular doctor in a timely fashion, or their doctor might be away or whatever. And I think it's really difficult for registrars to feel pressured to complete these forms for patients they don't really know. So we're empowering them to say, look, many times it's actually not appropriate for you to fill in those forms, and to try and give them some strategies and words to how to manage patient expectations at that time, to say, look, this is probably, it's much better being done by your regular doctor who knows you well.
Fantastic. There's been a lot of excellent comments tonight when you asked a couple of questions around what are effective ways of teaching boundary issues and professionalism to learners in our practice. You know, leading by example came up by Madhu, Conrad, be willing to share personal experiences. Brenda talked about case-based discussions, me sharing some of mine and the registrars sharing their thoughts. And Rob had a great suggestion, you know, in a small town, discussing those issues that have arisen over time in that small town to prepare the registrar so they don't sort of come in cold. So there's been some great comments on the chat box so far, and I have to mention again Nicole Higgins' comment, no S8 on the first date.
I love it. No S8 on first date. That is fantastic. I'm gonna shamelessly steal that, Nicole. Wonderful. Well, please keep the conversation happening. We will have another opportunity to check in and answer any questions or share comments at the end of the webinar. But for now, let's move on to the next section. That's sexual harassment by patients. So this is a topic which came into the media in about 2013 when there was a study published in the MJA saying that 55% of Australian female GPs have been sexually harassed by patients, 65% have been asked for an inappropriate examination, and very few of the respondents said they had been trained on how to deal with sexual harassment by a patient. So I'm reading this article and I sort of thought, well, I've never had any kind of training on that myself, and I don't think I've given any training on that. So for the next couple of years, as part of my role as a medical educator at North Coast GP training, I sort of tacked on a bit of a session on this, or a bit of a segment on this, as in a patient boundaries, self-care, doctor's health session. And it was really surprising to me how interested the registrars were and how keen they were to get some advice about how to manage it. The biggest questions or the biggest concerns people had is they just weren't sure whether or not they were overreacting. So the main concerns were, particularly for female registrars, when there were kind of sexually inappropriate comments by what would be considered, what they sort of considered, you know, harmless old men, for example, that they felt really uncomfortable. And they're saying, you know, am I overreacting? How can I manage this? What can I do? So it really brought up, I didn't quite realise how much of a need there was to talk about this. The male registrars too, some of them really struggled with both female and male patients making what they felt was uncomfortable remarks about their appearance, about their dress, etc. So there was a lot of things like angst around that. So I'm just going to go to the next poll question number 3, which is, have you personally had any training on dealing with sexual harassment by patients? So either as a registrar yourself or subsequently. Okay, just give another few seconds.
There's some interesting poll results there, Genevieve.
There sure are. So the results are pretty much 90%, 6% said they have had experience or have had some training in dealing with sexual harassment. 89% have said they haven't, and 4% are unsure. So that's by far the majority have not had any training in dealing with sexual harassment by patients, and that would certainly be consistent with the MGA study results. So the next question is, have you discussed this topic, which is dealing with sexual harassment by patients, with a registrar? And these are very anonymous, so just please be honest. Okay, so a bit of a mix here. So 12% saying they've talked about it proactively, 32% saying when asked, 48% haven't, and 6% not applicable. So again, the majority have not proactively talked about this topic, which again would be in keeping with the general figures of this not being a topic which is often discussed. So I'm not going to go into this in great detail. I just want to sort of leave it there to think about, for you to think about. But I particularly just want to leave you with my experiences. I think this is a topic that people very much struggle with. And while we do, I think, sometimes talk about having romantic type advances, or when we're looking at potentially sexual misconduct and that kind of thing. But I think it's less commonly talked about what some might see as harmless flirting, and where does that boundary exist? And essentially, if they're not comfortable, how to manage that with patients. So this is another example, I suppose, of again a bit of a personal disclosure here. So on reflection, I struggled with that a fair bit with a particular patient of mine as a registrar who would come in regularly and asking for rectal examinations. And he was an elderly gentleman who had recently lost his wife. He had prostatic hyperplasia, and he basically said that the prostatic massage helped release the secretions and helped him urinate more easily. So he sort of thought of this prostatic massage as a therapeutic benefit. But it was, without going into great detail, it was quite obvious that there was certainly a very inappropriate element to this request, and it ended up his language and his approach was very much overstepping the line. But it took me quite a long time to actually realise or come to have strong enough to sort of say this is not on, and to actually put some boundaries in place. And it would have been really helpful to me if I'd had a bit of a framework for that earlier, and instead of a feeling of, well, look, this is someone who is old and is grieving, and I just have to sort of put up with it. Because essentially it's not acceptable to put up with any kind of sexual harassment. Okay, so moving on to angry patients, another area which is that we all struggle with, and I'm really interested in hearing if there are any particular techniques that you use with your registrars to help them manage angry patients, and any kind of sort of patient complaints in an informal sort of setting. Ultimately, I think it is really important to registrars to know that they're not alone, and to get help and advice from you as your supervisor, earlier the better. Not only for their own support and well-being, but also because if managed actively early, there's much less of a chance for it ending up to being into a formal complaint. So the technique I tend to talk about a lot with registrars is the YES technique, and you're probably all familiar with this already, but just in case you're not, I'll just go over the elements of the YES technique. Essentially, it's the idea of when someone's agreeing with you, it's very hard to stay angry, or at least it does help settle their anger somewhat. So I suggest to registrars that they let the patient let off steam, so let them have their say and talk about why they are upset. But once they have sort of said their piece, the next step is to actually ask at least 2 questions, and preferably 3 questions, in which they have to actually answer yes to, or they have to answer in the affirmative. And the best way of doing it is by using some kind of reflective question that shows you have been listening to them and see their point of view. So reflecting on the, stating the facts back as you agree, so something like, so you're telling me that you went to the pharmacy after I had said that I'd faxed the script and the script wasn't there. Is that what you're saying? And they say yes, and that the fact that it wasn't there waiting for you was very inconvenient for you, and it's made you maybe you're quite upset. They say yes. So it's just going along those lines. So having some kind of relevant question, they say yes. So it's just going along those lines. So having some kind of relevant question instead of reflecting back in a way that doesn't need a response. There is something quite powerful in them actually saying yes to help get you together to at least move forward to then be discussing possible solutions. So talking about this and practicing this sort of role-playing this technique can be really quite helpful. There's a lot in conflict resolution, but it can be very, very helpful in a clinical setting also. So any particular techniques you have, please feel free to share them in the chat box. Okay, so we're just sort of running through various different topics, mainly just to stimulate discussion and sharing ideas about how we manage these kind of different issues involved with patient boundaries. We're going to go now back to Janet, who's our practice nurse. So we go back to Platypus Creek Medical Practice, and if you recall, Janet was our practice nurse, late 40s, had been working in the practice for several years, local girl, born and bred. So like the other staff at the practice, they do see the doctors at the practice for their medical care. And Janet has decided that Penny is a great doctor to see, and she saw her initially for some minor things like a urinary tract infection, saw her for her pap smear, just a couple of routine type appointments. But in the last couple of months, she's been seeing Penny with increasing frequency as she really has not been well in herself. So she has been teary, anxious, sleeping poorly, and is struggling at work. She's making errors, she's getting impatient with the patients, and she just feels that she's at nearly the end of the tether, pretty much at breaking point. And this has been going over the last 4 to 6 weeks. So Penny does a thorough assessment and takes history, and she determines that Janet is suffering from major depression. She diagnoses her as such, and given the fact that she really is not functioning very well at work, writes her a 2-week medical certificate for some time off. So Janet then submits her medical certificate to her boss, who is Dennis, who is also Penny's boss and Penny's supervisor. Dennis doesn't take this medical certificate very well. He feels that we all have stresses, we just need to just soldier through, and it's taking time off is just not the best option, he feels. So he tells Janet that he doesn't actually accept her medical certificate because he says, look, I've gone through your notes, and Penny is a registrar, she's in training, and I've reviewed the notes, and I feel that she probably overdiagnosed you. So I think that it's probably best if you continue working and we'll get some help in other ways. So both Janet and Penny were rather upset at this. Janet, after talking to her nursing union, decided that actually the root of her problems was probably not, the reason that she was stressed was probably because she was being bullied and harassed by her boss, Dennis. So she came to Penny and asked to do a work cover claim, looking at harassment and bullying in the workplace. At that point, Penny said, look, I'm really sorry, but I'm really caught between a rock and a hard place here. There's a conflict of interest. I really can't see you anymore for this problem, but I'll help you get some care somewhere else. Janet, needless to say, felt abandoned, and the whole thing just turned out very, very badly. So this particular experience is a very similarly disguised episode of what happened to me as a GPT 1 and 2 registrar. And this particular issue was very ugly at the time and was incredibly influential to me moving forward in my career about the dangers, potential dangers of dual relationships, and particularly seeing staff members as patients. So I want to now go to the 5th poll question. If you can launch that for us, please, Shelley. And this is there any specific guidance given or restrictions placed regarding registrars seeing practice staff and their immediate family members as patients in your practice. Okay, so some poll results here now. So we've got 18%, 38% of people saying yes, there are specific guidance given or restrictions placed. 53% saying no, there aren't any restrictions or specific guidance, and 10% who are unsure. So I wanted to talk a little bit about this with regards to staff as patients in a registrar context. Now, according to the medical board, it is recommended that we don't have, by the Code of Conduct, we avoid just providing medical care to anyone with whom you have a close personal relationship. Reasons given are lack of objectivity, possible discontinuity of care, and risk to doctors and patients. So that's the general Code of Conduct, and if we look at that in a broader sense, we can look at things like friends, neighbours, family, looking after yourself, etc. So we're not going to go into this topic in great detail. I want to focus tonight particularly on practice staff and registrars, as illustrated by the case we just discussed. So as far as general practices go, it is extremely common for practice staff to be seen as patients in a practice, and I'm not going to sit here and tell you that that is inappropriate or you shouldn't do that. I do, however, just want to caution you that, of course, there is significant potential risks available, sorry, not available, but that might crop up. But there are also, of course, going to be barriers, particularly in rural areas, when it comes to accessing other quality medical care. What you do as practice principals and partners and contractors is really up to you, but I would like to really encourage you to consider thinking about supporting your registrars in this context. You may have experienced in your practice that it's not uncommon for the practice staff to actually preferentially see registrars during their time, and part of that I think is because there is less of sort of a close relationship as far as if they are seeing their boss or someone they've been working with for 10 or 15 years. Sometimes it's not as easy for staff members to open up to people. Also, registrars tend to be easier to be getting to see, for example. It can be incredibly challenging for registrars to cope with this, and in many practice structures, they do feel quite low in the totem pole when it comes to power. And I've talked with countless registrars over the years who felt very much on the back foot when it comes to managing patient staff requests, when it comes to their medical care, and feel that they are not in a position to provide objective and comprehensive medical care to the staff members, but not sure how to handle it and not wanting to ruffle any feathers by saying that they don't want to see any staff member. So I would just encourage practices and supervisors just to consider having a policy that, if not for the whole staff or for the whole practice, at least saying that practice staff members shouldn't see registrars as patients unless it is an emergency situation. Or some variation on that theme. For those practices who have done that, I've talked to many practices around the country about this topic, and I've had some really good feedback from practices and registrars in which these kind of policies are in place. If you're interested in trying to think about a way of managing this more holistically in the whole of your practice, what you can consider doing is have some kind of reciprocal relationship with neighbouring practices. So after my quite disastrous experience as a GPT-1 registrar, when I moved to another town for my second year of training, we had an informal but very helpful reciprocal arrangement with another practice in town in which our staff members got pretty much preferential appointments when it came to getting medical care at the other practice, and they were bulk billed. And we did the same for their staff members. So that really helped decrease some of the barriers to care. And we made sure that our staff members were given the opportunity to go and get those appointments done and given time off work, etc. So that on an informal basis worked very, very well, and it did help minimise the boundary issues within the staff when it came to treating staff as patients. So just something to consider, but I'd really like you to consider it again, at least for registrars. They are inevitable, the dual relationships, and I've just got a slide up here about looking at some of the reasons and the risks that dual relationships can cause. It is something that all of us as practitioners need to manage and find the sweet spot and to keep working on that kind of balance that we need to have with looking at patients who are more than just patients. The term dual relationships, for those of you that are unfamiliar with that, simply means that you have a relationship with a patient outside the doctor-patient relationship. So as a friend, as a family member, as a coach of your soccer team, whatever, but the relationship you have is not just a doctor-patient one. So I said, although they're inevitable, they do require very careful managing, and I think it's something that we do need to try and support our registrars with as they come to terms with and try to get comfortable with where their levels of limits and where they sit comfortably in that spectrum. Particularly those that have only worked in large-ish setting centres and those just in hospitals, this whole concept of having a dual relationship can be quite new to them, and they do need lots of support. Okay, so going to just my last few slides here. Safety netting is really important, so keeping our registrars and practices safe within these kind of issues. We've had quite a mixture in the polls about people who opportunistically talk about this and those in these kind of issues, and those who do it preemptively. So I just want to encourage you to think about some of the issues we talked about today, and particularly for those registrars in their first and second GPT terms, and thinking about how you can integrate some more proactive discussion about these issues into your registrar teaching. And also thinking about practice policies, which can help strengthen this as well. And also the practice policies can then have a springboard for you to discuss those with your registrars during teaching. So I've just got a list here of some possible issues to consider if you're thinking about helping support your registrars through practice policies or guidelines development. So I won't go through all of those. You can have a look at those topics, and there may be some other topics as well that you think some guidelines will be helpful. I have seen practices in which they have sort of, as part of the employment contract, have addressed some of these and their expectations and guidelines around that, and again use them as a way of discussing some of these even before the registrar actually starts at the practice. They can be in the form of just quite a black and white policy on particular issues, or it can be simply some guidelines. I did work at a practice once in which one of the dress and behavioural expectations was that you were not allowed to turn up for work sunburned because it had a very poor role modelling for the patient. And I found that quite interesting. It was a clinic that did a lot of skin work and skin cancer work, but I always thought, I was very tempted, I never did it, but I was really tempted to one Monday just ring up and say, I'm sorry, I can't come into work today because I've got a case of sunburn. I never pressed that point. Anyway, you can have all kinds of things in those policies and guidelines, but they do provide some great guidelines for your registrars as they start in your practice. Okay, so we've now reached the end of our webinar. I'm just going to leave that issue slide up for the time being if people would like to keep reading that. And I'm just going to go to see if there are any final questions or comments in the chat box that we should address. So Shelley, over to you.
Thanks, Genevieve. There's been some amazing comments come through. Richard's just got a question about drug reps, how you manage the boundaries with drug reps.
Oh, absolutely fantastic question. So it does, I think, depend a little bit on each particular practice. And Justin Coleman, a good friend of mine, and some of the others that did a big push a couple of years ago to sort of say no to drug reps completely and not have any interaction with drug reps in practices. And some practices do go along with that. Many other practices do have drug reps who interact, and I think that it is extremely important to talk about how to critically appraise what drug reps tell us, and to role model the kind of drug rep behaviour ourselves. So as in how to ask difficult questions, not difficult questions, but ask probing questions of the drug reps. And I think sometimes, particularly if they're, say, coming in for a meal and discussion, having a debrief with the registrar afterwards can be actually a really good opportunity for some practicing of critical appraisal and critical reasoning, which, as we all know, are very important skills for a GP, and also important skills when it comes to things that is going to be examined. So, for example, the kind of things that I have done in the past when it comes to drug reps is that we've had a drug rep come talk about a particular medication, leave a glossy brochure. Then after they have left, they've sort of actually spent just a couple of minutes, say, at the registrar. So, so what do you think of that? Is that going to influence your prescribing? How is that going to fit in with practice? What do you think of this brochure? How, and actually talk about the way the information is presented as an educational tool to show absolute versus relative risk, etc., and how statistics can be skewed, and also discussing the motivations behind drug reps and behind drug companies in pushing products. So I actually think having drug reps interact with registrars can be actually really, really important and powerful, because it can then, with guidance, provide a structure for how to critically appraise information they get.
Fantastic, Genevieve. Actually, a couple of people have commented the same in the chat box as well about that. So there's been some excellent comments in there. Was there any other questions from anybody in the chat box tonight? We're sort of coming towards 9 o'clock, towards the end of our webinar. So any last questions before we sort of move towards the end?
I thank you all very much for all your comments. I didn't have the opportunity to read them all, as it's a bit hard to read the chat box and to present at the same time. So I have trouble not having verbal diary at the best of times, but if I'm reading and talking at the same time, it's not a pretty sight. So it'd be great if I can get a copy of those that chat box so I can have a bit of a read. I'm really interested in hearing what you all wrote. So final summary slide. I think we can all establish that teaching this professional and ethics is an important part of our role as supervisors, and that we need clear and consistent boundaries in a teaching practice, even more so than in a non-teaching practice, that we need to role model good behaviour, and that by producing practice guidelines and protocols, that can really provide a scaffolding and help for our registrars in some of these very difficult areas. So thank you very much, and thank you, Shelley, and thank you, GPSA, for supporting this webinar. We hope you found it very useful, and I really hope that you've taken at least some things there for food for thought to incorporate into your support and teaching of your registrars. So good night, everyone, and I'll just leave you with a little comment just from Ronald Reagan saying, peace is not the absence of conflict, but the ability to handle conflict by peaceful means, and encourage you to please fill out the evaluation which will be sent out after this webinar.
Thank you so